All right. Well, thank you for joining us. I'm Dr. Stephen Little. With me today is Dr. Al-Mallah. We will be talking about imaging for endocarditis. So welcome to Houston Methodist Multi-Modality Imaging Rounds. We'll do this in two parts. I will show some slides, and then Dr. Al-Mallah will take over. Hopefully, I think this is the one I want. Oh, goodness. Okay.
Dr. Little, I see two of you.
You're very lucky then. I don't know why there's two of me.
Mouaz, I only see one of you.
That's the studio, so you're live, Dr. Nabi.
Yeah, no, Mouaz, I see two of you now.
Maybe Tyree, it says share my screen, and then it's giving me all kinds of options that wants to open my preferences. Grant, let's grant access. Sorry about this. Maybe Tyree, if you're available, you could help out with this moment. Wow.
You can select screen one, and then it should allow you to get your desktop on.
Dr. Little?
Yep.
You need to share your PowerPoint. When you hit share, it should give you an option for like desktop or PowerPoint if you already had it open.
PowerPoint?
Yep.
Yeah. When I click it, it wants me to open system preferences.
That means your computer is not set up. Okay, can we flip flop real quick, and I can be in your office in a couple seconds?
That sounds good.
All right. So can the other doctor start, and I'll be on my way?
Mouaz, why don't you go first then, and we'll figure out the technical details.
Unmute. Let me go to get my PowerPoint. All right, and share screen. Screen one. Okay. So do you see my screen now? All right, do you see my screen now, Steve? All right, so I'm not getting response, but I'm assuming it's okay. So
we see it fine, Mouaz.
Yeah, I see it now. It looks fine.
All right, so I'm talking about CT, CMR, and PET and endocarditis. So I'm gonna start by this disclaimer. Echo is always first, not only on Twitter, but also on endocarditis. But there are many situations where it's not the last modality. So there are many times where echo is not the last modality, and you need additional information from other modalities to help guide the management of these patients. I'm tasked today to cover three modalities: CT, MRI, and PET, with some focus a little bit on PET, but also CT is, as our acronym here, CT is king. So there's a lot of role for CT in this. So let's start with CT. So CT role in endocarditis, most of the time, it's by the time the patient comes into CT lab, either we know they have endocarditis or they are suspecting endocarditis despite a negative echocardiogram. And what often sometimes we see in these cases, a vegetation, as you see here in this patient, or we see a major complication of endocarditis. Most often patients come to the CT lab because we are looking at for the complications of endocarditis rather than to detect the vegetation. Sometimes the detection of vegetation is more of an incidental finding when it has not been expected that much for that patient. I have to say that the vegetation is mobile. Our temporal resolution is not as good as echocardiography for detection of the vegetation, and that's why echocardiography remains the best tool to detect especially small vegetation compared to other imaging modalities. So how do we look at the accuracy of CT? These are multiple series that looked at this. CT, if you're detecting endocarditis or vegetation versus TEE, sensitivity is 97%, specificity is 88% in the series. If you're guiding it versus a final diagnosis of endocarditis based on operative findings, sensitivity goes up to 96% and specificity of 97%. And in terms of vegetation size and mobility, there was good correlation with an R coefficient of 0.95 and overall 96% accuracy. However, we have to remember the limitation and strength of each modality when we look at them. So CT has higher spatial resolution compared to echocardiogram. It allows for volumetric assessment. Obviously, it's preferred in patients with esophageal pathology. And most often, CT is looking for concomitant assessment of other pathologies. And in the era of COVID, it's preferred in the time where there is PPE crunch because it requires less PPE. Transesophageal echocardiogram is going to be covered by Dr. Little in a while, but it has higher temporal resolution. It allows for flow assessment. It's preferred in patients with renal failure or contrast allergy. Obviously preferred in very sick patients that cannot be mobilized to the CT lab, and it has higher infectious risk. And in terms of COVID consideration, there are many other reasons why would you prefer one modality versus the other. But if you're looking to where CT has an edge, is primarily to look for prosthetic valve dysfunction, looking for perioperative coronary assessment, and look for extracardiac findings. All the others may be done better or in similar sensitivity by echocardiography. That includes looking at valve dehiscence or regurgitation, looking at invasive complications like abscess or pseudoaneurysm, and looking for vegetation or leaflet perforation. And here's, for example, an example where you have dehiscence and perforation. And you can see also an aneurysm or pseudoaneurysm in this patient and abscess formation. Here you see a vegetation and also an aortic to left atrial fistula. You can see it here. Here's another patient where there is a complication with pseudoaneurysm. So it's been also penetrated, and now you see contrast in it. So it's kind of filling with contrast. There is always a question whether what we see is a thrombus versus pannus versus vegetation, which is like more of an infected thrombus. So we rely on CT and something we call the Hansfield unit, and the Hansfield unit measuring the intensity of these different structures or different tissue on CT. Water is usually 0, air is minus 1000, and each tissue has different intensity, and there are sometimes overlap between the different tissue parameters or Hansfield units. Obviously, calcium is very bright, so it has higher Hansfield unit. And here, for example, you see a patient who has a structure on the valve, and we want to know if it is a thrombus or pannus. And remember, thrombus is less than 90 Hansfield unit. Pannus would be more than 45 Hansfield units. So we can draw an ROI on this and see if it is a thrombus or pannus. And most likely this is a thrombus in this patient here. Looking at bioprosthetic valves, looking at different windows, we can assess degeneration in the valve and look at the valve if there is the valve regurgitation and if there is destruction of the valve by endocarditis as a complication. And here's a patient who also has a thrombus on the valve itself. We can look also for mechanical assessment of the mechanical valves and whether there is dehiscence. As you see here, the annulus is moving up and down, and we can replay it again, and you can see that there is also paravalvular regurgitation in this patient. This is a nice study that I found looking at CT versus 3D echocardiogram. So 3D echocardiogram has a lot of advantages in echocardiography, which we'll hear about, I'm sure, by Dr. Little, especially 3D TE. And this is a study that looked at 75 patients who had both tests within 3 days. The mitral valve was done, involved in 72% of the patient, and the aortic valve was involved in 50%. And here you see almost the same findings as you're looking here. There is an aortic valve pseudoaneurysm complicating an infective endocarditis of this bicuspid aortic valve. And you can look at color, obviously still frames, but this was used as an opportunity to compare the different accuracies versus surgical, compared to surgical findings as a gold standard. When looking at TE, most of the large vegetations were picked up by TE, 100%. Smaller vegetations were 94% picked up, and total was 97%. CT, as we discussed earlier, because of the temporal resolution, picked up 72% of the vegetations, and as the vegetation became bigger, it was more often picked up by CT. What I like here is those patients who had discrepancies, if we want to look more. Those who were TE positive but CT negative, most of them are in the smaller vegetation, less often on the larger vegetation. And this study looking for vegetation, there were none that were missed by TE and picked up by CT. So technically, if you're not going to see it by TE, it's unlikely that you'll be able to see it by CT. Now, where CT had an edge is looking at the intracardiac complications, looking at valve perforation, which picked up TE was negative, but CT was positive more in some patients. Valve aneurysm, perivalvular abscess was missed sometimes by echocardiography, but picked up by CT. Intracardiac fistula and dehiscence and pseudoaneurysm. So these are the areas that if you are suspecting them and you're not satisfied with the image or there is some discrepancy between the clinical course of the patient and the imaging finding by TE, you may want to get CT to help identify if there is any of these complications, including valve perforations, perivalvular abscess, which is the most common, and that we see in our lab sometimes in these patients, or pseudoaneurysms or fistula. We can also look at the newer bioprosthetic valves, the TAVR valves, and here's a patient of mine who actually had a valve. And this is her CT after the valve, which was done for other reasons. Later on, the patient actually came in with increased gradients, fever, and urosepsis. And this is her CT that she could not tolerate to undergo TE. And this is her CT, which is full of thrombus and vegetations. And unfortunately, this patient passed away within 24 hours because of sepsis and vegetation and infection. And this is data now from regarding association between TAVR and subsequent infective endocarditis and in-hospital death. And you can see those patients who have TAVR endocarditis, there is very poor outcome, especially in the first 6 months. In fact, the 2-year mortality was about 66.7%. Two-thirds of these patients were dead by 2 years. I think where also CT has a lot of edge is looking at extracardiac complications from brain abscess, but some of them are within the imaging window of cardiac CT, so we may see them like splenic infarcts, renal infarcts, or even sometimes aortic aneurysms, as in this case. And another application for cardiac CT, when you see a vegetation by echo and you want to assess the coronary anatomy before surgery, this is where CT adds a lot to the assessment of these patients if they don't want to cath them because of these vegetations closer to the coronary ostium. And there have been a meta-analysis looking specifically at these patients who may have high heart rate, may be difficult to control their heart rate. And in this meta-analysis, the sensitivity of cardiac CT is about 0.93%, and the specificity is 89% with high accuracy. So it can be utilized as a mode of assessment of coronary anatomy. And this is in a meta-analysis including all type of equipments. If you use the higher end equipments with higher temporal resolution, I'm sure these numbers would perform better because higher sensitivity due to better image quality in these patients. MRI, very similar to what we discussed a little bit before. It's mostly to look at complications, but given the longer test, and sometimes these patients are sick and may not be able to tolerate it, so it's not as much utilized as cardiac CT for this assessment. But most often MRI is utilized for the sequelae of these infections, looking, for example, for valvular regurgitation. And we had multiple lectures early on looking at the assessment of valvular regurgitation, which may be due to infective endocarditis, and also looking at some other findings like the pleural effusion that you see in this patient. So it's primarily to look for complications or sequelae of infective endocarditis rather than to diagnose endocarditis per se. Now let's move on to PET, and this is where probably a lot of the advances in the fields are happening right now in terms of endocarditis. This is a 78-year-old man who has an aortic valve implanted 3 years ago. And now you can see a lot of FTG uptake around the valve. And this is a patient who has an endocarditis, strep endocarditis. So you can see very focal, multiple areas of focal FTG uptake in this patient, which are very concerning for endocarditis. So first of all, how do we prepare these patients? Because sometimes we get the request that we want a PET endocarditis and can we do it this afternoon? If we are looking for endocarditis for a valve, it's not possible to do it same day because we would like to prepare the patient. We'd like to suppress myocardial uptake of FTG. So we'd like at least 24 hours of no glucose uptake. So the patient is switching to a fatty acid myocardial metabolism. And then on the next day, that night, we want 12 hours of fasting at least, preferably sometimes a little longer. And then on the day of the test, we give them heparin if there are no contraindications to that, wait for 15 minutes, inject FTG, wait for another 60 minutes for uptake, and then take the images to get an idea, imaging of the valve and endocarditis. If we don't prepare the patient, you can see here that the heart will take all the FTG. And if we are looking, for example, at the aortic valve or mitral valve, then there might be a problem to see the valve which is infected because there is a lot of FTG uptake from the background. However, if we are looking for an ICD pocket or other areas, then it may be okay. But most often, if we're looking for anything inside the heart from valves, from leads, LVAD, then it may be a problem if we have significant FTG uptake in the in the myocardium. Now, how does it look if there is normal? There should be no uptake. If there is infection, then you might have uptake, and we will discuss the patterns of uptake in these patients depending on the intensity and how aggressive. So these are the patterns. You may see a kind of very bad, if there is like an abscess, you can see a significant uptake, which is very heterogeneous. Endocarditis uptake is more heterogeneous than homogeneous. The second thing is that it may be very focal, as you see in this case, and it is like also not a full circle. Usually things that are full circle are less likely to be endocarditis unless there is like a massive abscess that you will recognize on CT. You may also see like sometimes involvement of the aortic root, as you see here, multiple focal abscesses at the ring level, but also involving the ascending aorta or the aortic graft. And here you see another abscess that's like very focal. So this is kind of the main message here, that FTG uptake is going to be more focal and heterogeneous. This is one of our patients where echocardiogram was uncertain about whether this patient had endocarditis or not. So we did a PET and CTA in this patient because we wanted to clarify if there is an abscess or not. So there were no vegetations in this patient, but the patient has been having constitutional symptoms, and you can see that there is a hypodense area which is suggestive of an abscess, and the same area lit up big time, and there's another smaller area which may not be easy to see on this reconstruction and also lit up big time, and this patient went to the operating room next day and had the abscess in the same two areas that we pointed out here. And this is just another view of it, of the two abscesses that we have in this patient. You can also detect endocarditis in TAVR valves, as you see in here, not only at the ring level, but even distant in the valve area. How often this technology is being utilized? Unfortunately, in the US, it's just starting to look. However, the Europeans have been kind of leading the way for this. And they put the European Endocarditis Registry, which I had the pleasure of participating in. And this study included a lot of prosthetic valves, native valves, and cardiac devices. And the main take-home message from this registry is that sensitivity versus clinical diagnosis was better in prosthetic valves versus native valves, which is in this registry was about 28%. So something to keep in mind, that this is a procedure for mainly prosthetic valves, much less often for native valves. And this is why an example illustrating why we don't think it's a good tool for prosthetic valves, for native valves. Here's a patient that we did PET in the literature where they did PET for the patient. No calcifications, nothing to suggest FTG uptake, although there is myocardial uptake, but there is nothing to suggest that there is a vegetation on there. And when you do TE, you see that this patient clearly has a vegetation and infection, which was completely not picked up by cardiac PET in this patient. So the main limitations here is that we have false positives. As we are learning our way, we are learning how to move around them. There are some abnormal uptake around the ascending bioglue that's been used. And if there are some prostatic thrombosis, sometimes there's some mild uptake from the thrombotic event. And sometimes early after surgery, there is still this inflammation, which may get difficult for us to identify whether there is an infection or not. So when it is not that intense, we are not usually sure, and we are more on a gray zone whether this is an infection or not. And in this patient, probably more related to surgical material, as you see on the CT. It's very sometimes difficult to make distinction whether this patient has inflammation versus infection. This is kind of a case from the literature on the extreme where there is very focal and heterogeneous uptake. So this one might potentially fit endocarditis. But on this other patient, you look here, now you start to see a lot of FTG uptake, and now you start to see even in the sternal wound. And this patient actually has severe allergy to the bioglue, and what you are seeing here is like significant inflammation from the bioglue allergy. There is a new pattern which just came like being described in the literature, which is more of the mosaic uptake, which you see across the valve, and this is more related to the surgical material that you see here. And there is like, it is usually more full circle or like almost a full circle, and it is homogeneous uptake, less intense. And this is one patient where at 1 month there was little uptake, then it increased at 6 months and went down at 12 months without any clinical symptoms to suggest that this patient is having infection. So we always try to look for more data when we are looking at this, and we want to be sure that we are not dealing with a full circle of uptake, suggesting that this may not be heterogeneous focal. So the one that we are pretty sure about that this is a endocarditis is focal, heterogeneous, intense. Focal, heterogeneous, and intense, as the other patients we showed you. When it is so homogeneous, it is more likely to be an inflammation, and it is more of a spectrum. So some of these, the multifocal may be infectious, but cannot sometimes rule out inflammation. This is actually a case that we just did a few hours ago, and I thought it's very interesting to put on the presentation. So you can see here that this is a patient with aortic root replacement, as well as the valve with the bioprosthetic valve. And you can see that there were some calcifications, and the concern whether this is an infectious process. And from the report, it says unclear whether the focal calcifications noted in the valves are infectious foci, and the valve definitely have degenerated and resulted in AI. And when we did the FTG, we can see that we have a very homogeneous focal uptake, not much focal, but very homogeneous, and the SUV max is 4.4. And here we're seeing some of the surgical material that the valve has, in addition to some of the calcifications on our low-dose CT. Now, going forward, looking at the image, obviously the patient did not follow the diet as well, and there is good myocardial uptake. However, it's not impacting a lot on our interpretation because it's a little bit far away. And this is where the aortic valve is. But if you look higher, now there's another hinge point there. And when I go and look at it at CT, there's also some surgical material that clearly this is the end of the graft there. So when I go and look specifically at that area of the surgical material, I see some focal FTG uptake, suggesting that, and this is the same SUV that we saw before. So this is what we are seeing here is all mosaic uptake from the surgical material or surgical glue rather than true endocarditis in this patient. The effect of antibiotic therapy, you hope that you see the patient, at least in our PET lab, without antibiotics or very early on in the antibiotic, because then we can detect the infection. However, if they come to you partially treated, the signal may be just so low that you may not differentiate it from the background. And that's a problem with partially treated endocarditis, that it may not be able to have enough white blood cells or infectious cells or inflammatory cells that will help us pick up the signal. So for native valve endocarditis, as I mentioned, from a meta-analysis recently, sensitivity 31%, specificity 98%. So if you see it, you're pretty sure it's there. And most often what we see are the abscesses, and these are like more of the burned out cases. For prosthetic valve endocarditis, we usually do much better with 86% sensitivity, 84% specificity. Where PET also has an edge is looking at extracardiac uptake, like you see here in osteomyelitis, discitis, and many of these patients actually do have this extracardiac uptake. We've seen also pulmonary infections and, pulmonary emboli, septic emboli in patients with right-sided valve endocarditis. And many of these are clinically relevant and help in the decision-making and management of these patients. There's always a question that can we do just like a regular white BC tagged scan with nuclear medicine techniques? And yes, you can definitely do that. It's a little bit more specific than FTG, which is uptaken and also in mild inflammation. The only problem with that, it has lower sensitivity. And here's a case from the literature where you see significant uptake, but no uptake with white blood cell. Just to mention that we don't only look at valves, we look also at pacemakers all the way from the pocket to the leads sometimes. And so it does help to look at these patients, and we have good accuracy for these. And this is a patient with pocket infection, pacemaker pocket infection. And looking at the accuracy, so this is the meta-analysis. I just coded you for the native valve and prosthetic valve. Looking at cardiac devices, our sensitivity is about 72%, and specificity is 83%. With newer systems like the system we are using here, we probably achieve higher accuracy. And it's very important to look at the non-attenuation corrected images to help you. And finally, looking at LVAD infections, and this is also another area which is very difficult to make that diagnosis. We've had few cases that have a lot of FTG uptake because the site of infection may be at multiple areas, starting from the drive line, moving on to the subcutaneous point, pump infection or outflow infection. So it can be at multiple points. This is a patient who has a drive line entry point infection, where we see significant FTG uptake, but also in the subcutaneous area, there's a lot of FTG uptake there. You can see it also in the outflow here, in the outflow track, where there is some FTG uptake. This is one of our patients with significant outflow infection, and you can see it here. It's like with very high intensity. And this is a driveline entry point infection in this patient, and you can see it on multiple cuts, whether black and white or colored. You can also look at subcutaneous driveline, so under the skin when it goes inside, or the worst of them is obviously if the pump itself is infected. And this is where there is a subcutaneous driveline, but there's also a pump infection. And here's the subcutaneous driveline infection, and this is a pump infection. And there have been some data to suggest that if the pump is infected, this carries very high mortality and poor outcomes in these patients. And not only the effect of infection, but also the SUVs are important in these patients. So where is PET FTG in the assessment and the guidelines? Unfortunately, if you look at different versions and you search for PET, nothing is going to come up in the American guidelines. The only guidelines that I come to know that has some information is just released, which is the 2020 ACC/AHA guidelines for valvular heart disease. And now it mentions about the role of PET-CT in the valvular infection. So I'll read it out for you so I don't misquote the guidelines, saying that abnormal FTG cardiac uptake is a major criteria added to the modified Duke criteria enable the categorization of 76% of patients with prosthetic valve endocarditis initially classified as possible. So if you have a patient who still possible, PET is your next step. And this tool may be used in centers with great experience with the technology, as this imaging technique may be prone to false positives, as I showed you, because of sterile inflammation. And FTG PET-CT may also be considered as complementary diagnostic tool for patients with suspected native endocarditis. And I think what they mean here is primarily to look for complications and extracardiac extracardiac uptake. And what you see here, this is from the valvular guidelines. If you have a patient after your initial workup, they come up as a possible infective endocarditis by the modified U criteria. FTG PET is the tool to use for these patients. European guidelines are a little bit more detailed. They have it now in the major criteria where it is abnormal activity as on the prosthetic site implantation detected by FTG PET. And they have clear pathways where to use it among those patients with possible prosthetic valve endocarditis. So with this, I'm going to stop and give it back to Dr. Little to talk about the echo first component of assessment of endocarditis.
Steve, you're muted.
Can't hear Dr. Little.
Sorry, here we go. I think that is that okay now? I hope.
Yeah, much better.
Okay, more technical challenge. Okay, so the first question is, what is a vegetation? This is what we need to define by echo is the first question. So there's some principal features on an echo. This is a transesophageal echo. The hallmark features of a vegetation is obviously it's a mobile mass, but the nature of the mobility has been described as oscillating. And really what that means is that the motion is relatively independent of the valve motion. So yes, it moves with the valve, but it moves much more than the valve. So generally the frequency of the motion should be greater than that of the heart rate. So that's one of the principles of an endocarditis mass. And that does sometimes help differentiate from other sources of intracardiac mass, which we'll talk a little about. So this is a large mass on the posterior mitral leaflet. It has all of those features. It is mobile, it's on the flow surface, and it oscillates. So here's a slightly different one. This is on the tricuspid valve. And you can see it's a much smaller mass, it's linear, but it still has that sort of oscillating character. It moves a little more. And think about those sort of balloon men you see at the used car parking lots that are 30 feet tall and they blow in the wind. Those are sort of oscillating, and that's often what a vegetation looks like. And this is somebody who is an IV drug user with Staph aureus. So one of the major features of a vegetation is that they do, by and large, for bacterial endocarditis, originate on the flow surface of the valve. So this is a graphic showing sort of how they might start on the mitral valve, but in sort of looking at an intracardiac mass and asking the question, could this be a vegetation? the more of these data points you gather that point to a vegetation, the stronger the suspicion. So flow surface generally is how they start. That's typically because the hydrodynamic forces on the flow surfaces and the sort of intermodal disruption are higher on that side. And why does that matter? Because this is the pathogenesis of how infective endocarditis occurs. So there's some sort of disruption of endothelium, inflammation. There's a little bit of fibrin deposition. On top of that, now you have a nidus or bacterial colonization. That's the very sort of beginning of a vegetation. And then it feeds back another layer of fibrin, a little more bacteria. And that kind of just circles in a loop until finally you have a very large vegetation or you have some local tissue destruction from the uncontrolled infection. On an H&E stain, this is classically what a bacterial vegetation would look like. And it's basically just a mix of platelets and fibrin with some inflammatory cells, and those are the blue cells. So because there are rules, there are also exceptions to rules. So this is a transthoracic showing a very unusual mitral valve. You see something on the anterior leaf that looks a little bit like a tomahawk coming down. And you have this sort of bulky and I would say relatively immobile stuff on the posterior leaflet. And I show this to emphasize the exception, and the exception is fungus. Fungus doesn't behave like anything else. It doesn't like to follow any of the rules I've just discussed. So just recognize that fungal endocarditis can be very slow growing, can be minimally destructive sometimes, and may not look like anything you've ever seen. So think about fungus sometimes, particularly in somebody who's immunocompromised. So this is the other sort of area where these rules don't need to apply is on devices, and particularly a pacemaker. So you can have, in this case, this is a right-sided view from a transthoracic image, and you can see a big bulky mass that is difficult to distinguish. Is it entirely on the pacer lead as it traverses the RA, or is it also attached to the tricuspid valve? In general, the one way to know is you remove the device and you see what's left. And this is after a lead exchange. And in fact, there was actually no vegetation of any kind other than what was on the lead. So it can be very difficult to determine exactly the nidus. But if there's prosthetic material, you can be sure that the vegetation will at some point have connection to the prosthetic material. This is a sort of a zoomed view of a pulmonic valve. And this one you have to look a little more carefully at. It's very long, it's linear. Classically, the pulmonic valve can be difficult to see from a transthoracic view and sometimes even difficult from a transesophageal view. And in this case, when you're unsure, is this really something occurring on the pulmonic valve? Often we look for function. And when you add the color Doppler, you can clearly see that there's a lot of pulmonic insufficiency. Again, the story helps. This is an IV drug user with bacteremia with Staph aureus. So this is pulmonic valve endocarditis with near total destruction of the pulmonic valve. So we know about infectious endocarditis. What about non-infectious endocarditis? This is something that's a little more subtle. Again, when you look closely, and this is perhaps going to increase in frequency and diagnosis as our echo machines get better and better, and as the resolution, both temporal and spatial, increases, you see, if you look closely at the mitral valve, there are thin, little filamentous things near the tips, and with the little clinical story, this becomes more obvious. So Liebman-Sachs endocarditis are these flat, generally sort of pale on histology. They spread all over the mitral surface and even down into the chordae. And they can be associated with SLE, antiphospholipid antibody syndrome, and even malignancies. So that's sort of we don't see a lot of those, thankfully, and usually the story is obvious. Rarely is the diagnosis made from an echo, but certainly the cardiac involvement of a systemic disease is an important thing to recognize and is diagnosed by echocardiography. So one of the very important things in the echo review is to recognize the complications of infectious endocarditis, and these can be overt and these can be subtle. So this is a transesophageal view of both the aortic valve and the mitral valve. And on first blush, it may look pretty good, no large bulky vegetation. Although when you look at the base of the posterior leaflet, you see a little flicker here. Hard to know immediately, is that atypical calcium? Is that some tissue coming in and out of plane, or is that in fact pathology? When we add the color flow, which is important. And when I provided you a freeze frame, you can see that there is mitral regurgitation, but it's not coming from the coaptation zone between the anterior and posterior leaflet. It's actually coming up here under the posterior leaflet. So that's very concerning for perforation. So be aware, and this can be particularly challenging if there's flow both at the coaptation zone and somewhere extra coaptation. But this is another freeze frame to show you that in certain views, you actually can see a fairly sizable hole. And there's a fairly small vegetation here, but a large defect. And the defect doesn't have to reflect the size of the vegetation. And if that leaflet were to be removed, you would see something like this. And this is often sort of the site of perforation. There's this heaped up, almost like the top of a volcano appearance when there is a perforation. If this is very large, it can look like a windsock deformity, which is usually a manifestation of chronic infection. This is a descending thoracic aorta with a mycotic aneurysm. This is sort of the worst of all combinations. There's here both a dissection, there's an infection of the aortic wall, and there's a vegetation. So the term is a mycotic aneurysm, also been termed mycotic endocarditis. It's a bit of a misnomer because it's not often fungal, in fact, so mycotic is maybe not the best term. It's more often bacterial, but it's still often termed a mycotic aneurysm. And we often use that term to simply mean an infection distal to the heart. And this has penetrating ulcer, vegetation, and dissection flow. So a few minutes on what's different about prosthetic valves. Well, one of the challenges, and Dr. Al-Mallah showed this very nicely, and really one of the benefits of the applications of CT is really seeing all of this peri-valvular tissue that you see very well on CT. So many different valves these days, put in different ways, some with lots of inflammation, some with less inflammation, some with different healing profiles. It can be very challenging to understand what's normal in the peri-valvular tissue. This is a question. This is somebody who had recurrent fevers. And the valve function at first looked pretty good. This is a transesophageal echo. This is somebody who'd had a prosthetic valve implanted several months earlier. And if you're looking closely, you don't see a whole lot of concern on the mitral leaflet. Difficult to ascertain what's happening on the prosthetic aortic valve. But a little downstream, you do see this wiggling mass here. So that is still endocarditis. It doesn't have to be on a valve. It has to be on an endocardial surface. So this would qualify being in the proximal aorta. And in fact, this is a TE, so this is posterior, this is anterior, and this was actually the site of the aortotomy that the surgeon made to do the valve implant. There was a tiny piece of suture there, and when they went in to remove this, in fact, this was an infectious mass that had adhered to the suture site of the aortotomy. And that was the vegetation, and that was indeed fungal, which is, again, common in immunocompromise. The other opportunity is with an open chest or a surgical intervention. This is a different patient. This is somebody 4 months after a bioprosthetic aortic valve. This vegetation is less subtle. You can see it coming off the leaflets. It's very long and linear. And at the time of surgery, this was looked like this on the right. And then this was actually ended up being nocardia. It took quite a long time to get to that tissue recognition of that infectious agent, but nocardia, particularly in the post-op period, even months later, as a concern. This is a case from several years ago. This is a 3D TE of the mitral valve, and we see a long linear strand. This is somebody who'd had a surgical mitral valve repair. And I think you can just make out that there's a ring. These are some of the early days of 3D TE when we had to use some stitching to get a volume that big. This is the 2D TE. This is the 3D TE. This is the appearance. And we've actually had these referred for concern about endocarditis. And in fact, that's not endocarditis at all. This is an Attune surgical ring made by St. Jude, used for the annuloplasty. It has these long sutures, and this was a surgeon from another state who did not know to trim or cut or do something with this. and it forever stymied every echocardiographer for years later. So not an infectious agent at all, but simply needed a little deep dive into the report and the chart and to understand what the patient had been through. So it was long, linear, mobile, and oscillated, but it was not infectious. So this is a mechanical mitral valve, and there's a couple of things that are quite concerning. Simply just the mobility. You can see how much it's rocking. And if you look where the annulus so ring should be, there's a large space here. So this is actually starting to dehiss. So there's a very large paravalvular defect here. But I show this slide to emphasize that rarely would you get a mass adherent to the pyrolytic carbon or the metallic elements of the leaflets. But really it's the sewing ring and the supporting structures around where the vegetation will adhere. And this is a nice example of this little piece flicking up and down. And it's not hard to imagine that if it were just a little bit bigger or the timing was off just a little bit, it would actually wedge itself into the valve and either cause stenosis or considerable regurgitation. So this patient did require a surgical mitral repair. Now, bioprosthetic valves can behave a little differently, and they actually have biologic tissue as the leaflets. Bacteria do like to adhere to biologic tissue, so you're much more likely to get vegetations actually on the surface of the leaflets of a bioprosthetic valve. You can still certainly get adherence to the struts and the sewing ring and the perivalvular tissues, but you can actually get local and focal destruction of the leaflets. And this is a nice example of a bulky mass adherent to the leaflets themselves. Guidelines will tell you this is a surgical problem. Occasionally, a patient can have such profound comorbidity that the survival rate of surgery is deemed low and some palliation with antibiotics is attempted. This is that same patient, believe it or not, after 6 weeks. So you can see that the bulk of that vegetation is gone, but the leaflet's not entirely normal. Now, if you look at this image on the left, you can see that this cusp does not open fully. But the antibiotics were quite impressive at debulking this tissue. However, if we look at 3D, we can see that in addition to some thickening of the leaflets themselves, we now have paravalvular tissue damage and regurgitation spots. And we can see here again some of the bulk of the leaflet that's occurred after antibiotic therapy as a consequence of infection. And we now have 3 focal spots of paravalvular leak. So it's certainly not the standard treatment approach to give antibiotics, but if somebody cannot have surgery or is not expected to survive surgery, it is sort of a backup plan. This is probably the only case I have encountered with a good long-term outcome. This is a mechanical valve in the mitral position. Again, we're hyper-focused at looking for vegetations in this discussion. None around the rim, none on the mechanical leaflets, as you would expect. This up here, we often sort of, this is just some sort of weird dropout on a 3D. But of course, in this case, that's not. That's actually a real big problem. That's total valve dehiscence. This was a scenario of culture negative, despite multiple cultures. But this patient had a prior history of endocarditis, had a very extensive surgical repair out of state. And the culture negative was much more likely because of recurrent antibiotic exposure and not true absence of bacteria. So the cardiac crux is important when considering endocarditis evaluation by any imaging modality, just recognizing what the crux is, the center cross, if you will, of fibrous tissue and how close in relation everything is. This is a 75-year-old who had a bioprosthetic aortic valve, now comes in with fevers and chills. This is the initial transesophageal image. Have a look and I won't comment further. Hard to see because of shadow if there's anything truly within the aortic valve, certainly nothing appreciated in the subvalvular apparatus or in the LVOT. On an X-plane image, we can start to see a bulky mass within the valve, and you can see it not as well on the short axis, but highly suspicious here. But not only is there a likely mass in that view, but we have a very significant outflow tract obstruction. So that's one of the other manifestations of endocarditis, particularly within a prosthetic valve, is it can actually be obstructive in nature, not just destructive in nature. And in this case, we have almost a 5-meter jet. So severe aortic stenosis in the setting of bulky vegetation. Again, some antibiotic care in this case. The mass is gone, the gradients are impressed, very short-lived celebration, and that we don't see the mass, and short-lived because of this, and because you see this lucency anterior to the valve, and this is a periaortic abscess, and this is classic. And in fact, if we look back at the very beginning, the first echo, we saw the beginning of that abscess. So it's easy to be hyper-focused on the vegetation, but in this setting, we have to be very concerned and vigilant about a surgical indication at the beginning. And this was actually there in this scenario. So the heart anatomy is close, aortic valve, the left and right fibrous trigones, and the two AV valves, all in this little crowded space. It's important to think about all of this as we evaluate with imaging. This is a 3DT of anterior and posterior leaflets showing the intervalvular fibrosa and how close it is. And this is from the undersurface, from the LV looking up. There's the intervalvular fibrosa. So a vegetation here or here will easily interact with your intervalvular fibrosa. Well, I'm showing that for this reason. So here's an aortic root abscess and a native valve. You see this clear thickening of tissue here. That might be near normal if it was the immediate post-op phase after an AVR, but certainly not a native valve, and probably even that would be too much periaortic thickening. So that's the very first sign of an aortic root abscess. This is a different patient, but this is an actual root abscess, pseudoaneurysm, and ultimately rupture. All with endocarditis. So this is an incredibly destructive case of Staph aureus with an LV abscess, thankfully very rare. This is the classic aortic root abscess where you have this sort of pocketed fluid collections, very large, difficult to miss this one. You can see it playing there, and that's the standard. You have some light fluid filled, some more dense tissue, all mixed together, classic abscess. This is a pseudoaneurysm, and the nomenclature matters. So this is a mechanical aortic valve. Reason it's a pseudoaneurysm is that it's only open at one end, and the pulsatility gives you that hint. So if it was open at both ends, it would be less pulsatile. So open at one end is a very pulsatile, and you can document that with color. You can document that with M mode. You see flow in and flow back out again. That is still a surgical indication. Some therapies could be altered by the fact that it's not open at the other end, but that's a pseudoaneurysm. In contrast, a fistula is now open at both ends. So the flow goes all the way around, both in systole and diastole, and you can see it's much less pulsatile because it's not containing pressure the way a pseudoaneurysm does. And this is an example of a aortic root to RA fistula. So in summary, endocarditis is inflammation of the endocardium. It usually involves the valves, but other structures can be affected, the septum, the chordae, and any, of course, intercardiac device. The prototypic lesion is a vegetation, which is, remember, is a mass of platelets, fibrin, organisms, and inflammatory cells. Echo is the mainstay for both the diagnosis and the follow-up of treatment. And normally I would now introduce Dr. Al-Mallah for his talk, but I think you've seen great evidence that CT and particularly PET have really established a role. So I think I'll stop there. I don't know if we have any texted questions. I'll look at the chat here. Nothing. So I think that's all we have. And we're just about on time. So on behalf of Dr. Al-Mallah and Houston Methodist, we thank you for joining us.